The primary outcome, as I said before, was a change in interlimb difference where they had a 5% increase, which was a way of denoting that they had had a worsening of their lymphedema on an objective scale. And what you can see is that 11% of the women with lymphedema had that increase in the treatment group and 12% in the control group, with a cumulative incidence ratio of 1. So really no difference between the groups. However, when we look at the proportion of women who had a clinically defined flare-up of their lymphedema that required intensive, complete decongestive therapy delivered by a certified lymphatic therapist, we cut the proportion of women who had that kind of flare-up in half. 14% in the treatment group and 29% in the control group. So there's a couple of take-home messages here. One is women who have lymphedema have flare-ups. 30%, nearly 30% of the women in our study who had lymphedema had a flare-up over 1 year of follow-up. That's never been published before. It's never been published before. Nobody has ever done a longitudinal observational follow-up with objective measures or clinical measures where people have actually looked at those arms and said, yep, you need treatment or not. Okay? So we anticipated, based on review of clinical files at the University of Minnesota, where I was when I designed this, that we would see 10%. So it's much more frequent than you might expect it to be. The second take-home is that the flare-ups were cut in half, even though we had blinded physical therapists. And yes, that's a lovely image, isn't it? The blinded physical therapist. But they didn't know which group the women were in when they were doing these evaluations for flare-ups. We did also see that the women with lymphedema who were in the treatment group, who did twice-weekly slowly progressive strength training, were more likely to reduce the number of symptoms that they endorsed, lymphedema symptoms that they endorsed, and that their symptom severity went down more than in the women who did not do the strength training. So the question that comes up, of course, is, well, if this is true, if your findings in the lower portion of this slide are true, why didn't you see a change in the objective measure? And there's certainly the possibility that we had some kind of break in the blind. There's certainly the possibilities that there's something wrong here. Another good possibility is that we, in ethical conduct of research, had to provide treatment. We had to provide treatment for those flare-ups. Well, if you treat a flare-up, then you don't have an increase in the volume. So we, in essence, because we had to follow standard of care, we observed a flare-up. It's sort of like saying, well, you know, if somebody had a recurrence of the cancer, no, we're not going to treat it. We're going to see what happens and see if this intervention we did before was good enough. It doesn't fly. Standard of care would not allow us to do that, right? So we kind of shot ourselves in the foot for the ability to look at whether or not we had any change in our objective measure. Okay. So here's what happened in all of the women without lymphedema. This is unpublished results. They are in review, and fingers are crossed, things look promising for publication. So in the 154 women without lymphedema, we do see that fewer women had a 5% interlimb difference increase, so increase in swelling of 5% in the treatment group than the control group, but it did not achieve statistical significance. And the number of women, or the proportion of women who had a clinically defined onset, was exactly the same in the treatment as in the control group. And they didn't endorse symptoms at baseline, so it's not really all that terribly surprising to find that we didn't see a difference between groups in the number of symptoms endorsed or symptom severity. The problem with this slide, and the problem with concluding anything based on this slide, comes from, and I need to tell you about what happened with the paper for the pilot. In the WTBS study, the pilot study, the 2006 publication, Ahmed et al., Rehan Ahmed was my doctoral student at the time, the expert reviewers required that we remove all women who'd had a sentinel lymph node biopsy from our analysis. So remember I told you that there were 85 women in that study? Well, we only published on about 40 of them, or 42 of them, in the JCO paper from 2006, because the reviewers said that the risk of lymphedema was so low in the women who'd had sentinel lymph node biopsy that we were giving false conclusions that it was safe for women to do this program of exercise if we included them. So we redid our analysis, and it turns out that we were adequately powered to be able to draw the same conclusions with half the number of people, thank God. And they went on and published the paper. Well, so this includes women that had sentinel lymph node biopsy. Okay? In the JCO paper, we excluded women who had 4 or fewer nodes removed. So we went back and did the same thing. In order to look at women who were at elevated risk for lymphedema as a result of having 5 or more nodes removed. And here's what we saw. 7% of the women who had, of the 96, out of the subset of 96 women who had 5 or more nodes removed, 7% in the treatment group had a 5% interlimb increase over 1 year, 22% in the control group with a statistically significant reduction of risk of arm swelling of 5% or greater, 70% reduction. Cumulative incidence ratio of 0.3. So we have achieved prevention. The clinically defined onsets. We also see a similar cumulative incidence ratio, 0.37. It is not, however, statistically significant. What I would suggest to you is that it's not statistically significant because it's so low. Our clinicians were pretty conservative in deciding whether somebody had onset of lymphedema clinically. Clearly, 22% had a 5% interlimb difference increase, but only 6.5 of them were deemed as having developed lymphedema by the conservative therapists at my institution. As I said before, few of these women endorsed any symptoms at baseline, so it's not really all that surprising to find that we did not see differences in the number of symptoms endorsed or symptom severity across groups in this subset of the population. So in summary, from the PAL trial and WTBS, it appears that twice-weekly slowly progressive strength training is safe for breast cancer survivors who have had lymph node removal, including those with lymphedema and those at risk for lymphedema. We find that the risk of lymphedema flare-ups decreases by half. This is, brings up the question of cost effectiveness, given the fact that the medical care for women with lymphedema is about $11,000 higher in the U.S. than for women without lymphedema who are breast cancer survivors, among breast cancer survivors. Among women at risk for lymphedema who had 5 or more nodes removed, the risk of increased arm swelling, clinically meaningful increase in arm swelling, was reduced by 70%. We also see substantive strength improvements, and although in the interest of time I have not focused on it, we also substantively improved body image in this population. That is a published finding, Speck et al. So we have this, supposedly evidence-changing data, right? So now go do this, right? It's hard to translate things like this into actual clinical practice and get people to provide this programming. The media coverage was extensive. There were a lot of phone calls. I had a lot of emails. So, we had the director of the YMCA Live Strong at the Y program on the national level is Ann Hillary Heston, and she was emailing me daily saying that the YMCA phones were ringing off the hook. Okay? So we also have done some assessments since then to show that the intervention is actually sustainable for the women who were in the study. 40% of the PAL participants reported still doing weight training 1 year after the end of the trial. The control group women got the intervention at the end of participation, so they were included in this figure. The proportion doing weight lifting a year after the trial was the same in the treatment as in the control group. So now what? How do we do this? How do we disseminate this kind of activity? There are reimbursement issues. There is the issue of the need for appropriate evaluation and treatment prior to starting and upon symptom changes. There is a lot of training to be done for PTs and fitness trainers. There's also the issue of the provision of compression garments. In the U.S., they're not covered by insurance. Are they covered by insurance here? Only if you have third party. Okay. All right. So there's also the reach. 295 PAL participants represent a tiny, tiny, tiny proportion of survivors in our area. We mailed letters to 28,000 women to get those 295 survivors in a 6-county area. But the value of sustaining and growing this program seems high and is clearly of interest to a number of clinicians and to the survivors themselves. So then the question is, okay, how sustainable is this within the Ys? Can the Ys take this based on the fact that I spent time training 17 trainers at the YMCAs, at 3 different YMCA associations, okay, that had 8 different fitness centers included within those structural organizations. Were they able to take this and then grow this program and teach it to new survivors? We have one success story out of the 3 associations. In the Community YMCA of Eastern Delaware County, there were 2 fitness centers total within this association. 3 fitness trainers were trained as a part of the study. 1 of them remains. The other 2 have moved on to other opportunities in their lives. The lead trainer was also the fitness center director. She was trained for PAL. She then took it upon herself to make the PAL intervention available to new women after the study and to expand it to other tumor sites as well. She started in 2009. She expanded, as I say, to other cancer sites. She slowly added other types of exercise to make it kind of her own program. Her recipe for success was really that she was the in-house champion for getting this done. She was a long-time staffer, and she had some power and some ability to sit at the table of the leaders at this organization. There was also a very nearby hospital that previously was involved in PAL, to whom she could then refer women for the evaluations and for follow-up if there were any problems. She included an extensive pre-program evaluation so that she was sure that women were safe coming into the program, and she made sure that there was a physician signature for anybody who needed one who had a pre-existing health problem. At the point of contacting her at the beginning of the summer, she had done 20 participants and had another group starting with 8 in the summer. Unfortunately, the other 2 organizations did not fare so well. The Burlington County Family YMCA also had 2 fitness centers. We trained 5 fitness staff. None of them remain on staff, not one. They also became part of the national initiative funded by the Lance Armstrong Foundation called Live Strong at the Y. It's a grantee program where YMCAs are then taught to build capacity to understand the unique needs of cancer survivors and build programming for them. The programming that they did also started in September of 2009, and they have only had 15 participants beyond PAL repeaters. So a number of the PAL women went back and did their program because it was free. So ongoing challenges at this Y included marketing. There was no obvious way to connect to the cancer center because that was really important. There was finally some fantastic forward progress before the key staff member was released from her position, and in some reorganization of the group, and just in a horrifying twist of fate, diagnosed with breast cancer the following week. So at the Philadelphia area YMCA, one of the oldest and most wealthy YMCAs in the United States, 11 fitness centers, an enormous organization. We trained 10 fitness trainers as part of PAL. 3 of them remain. There's no management level champion. Penn refers patients directly to the remaining trainers for personal training outside of the Y because the Y has been so difficult for us to work with. Approximately 15 patients have followed through out of the 800 per year that come through Penn. Clearly major challenges. Staff turnover. Of the 17 trainers trained to deliver this intervention by me, only 5 still work for the Y. Who's going to train the new staff? Who's going to pay for that? I offered a training to the Philadelphia YMCA. 4 people showed up out of the 1,200 trainers that work for the organization. Who will train the new staff a year from now? Who's going to pay for that? Marketing. The survivors need to know that this programming, any programming that they're sent to, is safe and effective. I have, horrible stories that I can share with you about people being sent to programs where there's not been adequate training of the fitness professionals, and trainers who, the women would say, my arm feels puffy, and the trainer goes, okay, come on, let's go do, and they keep going. So there is a need for capacity building. There's the pre-screening issues. Who's going to ensure that all the survivors who walk through the doors of these Live Strong centers are actually trained to know what kind of appropriate evaluation needs to happen? There needs to be the